Kapil sir, who is the Secretary of National Academy of Medical Sciences, to welcome all the welcome the speaker and the audience.
So what I will do, I'll just give you a small background of this National Virtual CME program, which has been initiated by National Academy of Medical Sciences. This is essentially for the students who are preparing themselves for the MD, MS examination. One, those who are doing as a part of their post-graduation, they are doing it. Also for the DNB students who wants to get into the DNB or already doing the DNB course. Now, if you look at the national scenario, we have about 95,000 MBBS students who pass the MBBS examination every year, and out of which about 7,000 or so get, or 8,000 may get into the MD, MS exam, degree courses. Rest, again, they try for the postgraduate course. Similarly, about 8,000 students get into the different DNB programs, which is done by the National Board of Examination. Now, what happens to the remaining 80,000? It's a large body of medical graduates who wants to get into the postgraduate courses. Now, essentially, the National Academy of Medical Sciences have a responsibility of, it's a national responsibility of undertaking CME, this is continuing medical education. In that series, we initiated lecture series. Initially, we had 5 sessions. In each session, we had 2 lectures. That's about 10 sessions. They were essentially devoted to the emergency medicine. Subsequent to that, we have switched over, as per our experience, that what we should do is to have thematic series of lectures. And in that context, we requested Dr. Manya Prasad, who is an outstanding epidemiologist in our country, and she has been responsible for taking a large number of international epidemiological courses. So what happens is that she is going to undertake the first lecture on the theme of epidemiology and biostatistics research. And today's topic is essentially introduction to the basic concepts in the research. Large number of people, look, if you ask me honestly, Delhi and AIMS doesn't represent the country. There are large number of institutions. The postgraduates needs guidance. They need hand-holding as far as research is concerned. And if you look at the national scenario, almost 60 to 70% of the research publications, they come out from institution of national importance, AIMS, and other PGI, and so on and so forth. What is important is that research is an important area where we are not able to contribute much from the large number of medical institutions in our country. So now we have started this a series of epidemiological courses, and in which we'll have 6 lectures. We'll have thrice in a week, that is on Tuesday, Thursday, and Saturday, for 2 hours duration from 6 p.m. to 8 p.m. And this has an inbuilt system to get feedback from all the attendees. That's very important. It will help us in improving it will help the speaker to improve their presentation. And this also help us in getting assessment of the speakers by the attendees. So this is in brief about the this particular Navigate program. And we request you to join on Thursday and Saturday from 6 p.m. to 8 p.m. Please do write us if you want to change the timing, days, and so on and so forth. We are very open, very flexible as far as these parts is concerned. With this, I again welcome you with my core of my heart to be a part of this initiative which we have undertaken. Please help us. Thanks again. Thank you very much. Over to you, Dr. Preeti.
Thank you, sir. Thank you, Dr. Manya Prasad, for accepting our invitation and joining us here. Dr. Manya Prasad is an assistant professor of clinical research or epidemiology at Institute of Liver and Biliary Sciences, New Delhi. Her chief areas of interest includes clinical epidemiology, guideline development, medical research, systematic reviews and meta-analysis, and evidence-based medicines. She has more than 2,900 citations with a Hutch index of 20, ITIN index of 26. She has 43 international articles in Medline Index Journal and has facilitated many workshops on research methodology, evidence-based medicine, and grade 2. She also has won gold medal in her MD final exam, and she is a recipient of International Epidemiology Association Fellowship. I welcome you, ma'am. Over to you, ma'am.
Thank you so much, Dr. Preeti, and thank you, Kapil sir. I am delighted to be here. And I thank you so much, Dr. Sood and the entire team at NAM for this very, very remarkable initiative to disseminate knowledge among the postgraduates of the country. What I will try to do in these sessions is present concepts in easy language related to clinical epidemiology, and I will cover concepts related to biostatistics from the clinical perspective. So I'm not a biostatistician. The way I will present concepts of biostatistics is from a clinical epidemiology perspective. And I encourage you to please make these sessions as interactive as possible. It's wonderful that we are running this in the meeting mode, which facilitates engagement of participants. And in fact, these sessions will work best if there is maximum interaction. So I encourage you to please send in your questions in the chat box or raise your hand if you want to speak up. I encourage you to interrupt whenever you have a question. And there will be some interaction within the sessions as well, which I encourage you to participate in. So without much ado, let me start with what is today's topic. We are talking about introduction to research methods. And today we will talk about the very basic overview study designs that are there, following which I will talk a little bit about formulation of objectives of your research. And you will see that as we go further down in the list of topics, they will become slightly more advanced. So we have RCTs and observational studies and systematic reviews, etc. Planned further ahead. But today I will just be providing the basic overview of study design. So let me begin by asking you a very simple question, which you can just tell me the solution to by common sense, okay? So you don't need any prior knowledge of epidemiology, no prior knowledge of research methodology, nothing you require. If I ask you that, there's a national problem that administrators are seeing in the country, they are seeing that the number of surgeons is dwindling. So the number of surgeons in the country is becoming fewer and fewer. And so they think, oh, okay, this is a problem. So what do we do about it? And so one of the administrators in the Department of Medical Education, he said that, maybe medical students who are good at anatomy in first year MBBS, they are the ones who grow up to become surgeons. We don't know if that's the case. That's just one question he had in his mind, right? So he said that do medical students who are good at anatomy in first year MBBS, they are the ones who grow up to become surgeons. Now, from just common sense, can you just tell me what are some ways that you could possibly test this question? You could possibly arrive at a solution to this question that this person has. You know, medical students good at anatomy grow up to become surgeons. So I encourage you to unmute and answer. Anybody can answer. Anybody want to venture a solution to this very important problem of dwindling surgeons in the country? Okay, let me ask you, or maybe you can type in your answer in the chat box. What if I do this, that there's an API conference that happens every year, and I go to that conference and I give out MCQs, MCQ tests for anatomy. And I see if the surgeons who are attending the conference score better at anatomy than the physicians or the non-surgeons. Do you think that's a good solution? And if not, why? And you can again unmute and answer, or you can chat, or you can drop in your answer into the chat box. I'll give you just a couple of seconds, maybe 30 seconds to think about that. So what if I go to API conference and I give out MCQ tests for anatomy, and I see whether surgeons are scoring more? Will that adequately address this question? Okay, so somebody has said prospective study will be better, right? So what is exactly meant by that? So how would one run a prospective study for this question?
Ma'am, if may I?
Sure.
Ma'am, like we can take up MBBS students who are in the first year, and we can get their scores, and then we can like follow them up and find out whether they are becoming surgeons or not.
Right. So very good. And one other participant, Dr. Siddharth, has also said follow the students good at anatomy. So that would mean that we go to medical colleges in the country, and we see the marks that students have scored in their first year, MBBS, and then we follow them up. So maybe 5 years of MBBS, and then maybe we want to see if they complete their MS or not. And so we see whether the ones who were good at anatomy and those who were not good at anatomy, you know, what proportion of them end up becoming surgeons and not surgeons. So maybe 8 years of follow-up, right? So you will have to follow up the students for around 8-10 years, right? All of them will not secure MD seat in the first go. So that is one way, absolutely correct. This is a wonderful way, and that is actually very robust, because you have before you students who are good at anatomy, who are not good at anatomy, and you follow them up for many years, and you see who becomes surgeon or not. Excellent. There's somebody who said follow the skills of those who were good at anatomy. Exactly. So that's exactly the same thing. You go to first year MBBS students who have passed out, and you check their marks, and you see who end up becoming surgeons after 8-10 years, right? All right. So another one is retrospective cohort. Those who were surgeons, trace them back. So we're not talking in technical terms right now, so I'm going to forget about retrospective cohort, what you said there. But your solution is those who are surgeons, trace them back. Right. So that is one other way. So say you don't go to medical colleges, don't go to MBBS students. You go to surgeons in hospitals, right? So, and you go to a hospital and say, so I'm in ILBS. So you come to ILBS, and there are both surgeons and non-surgeons here. And you ask them, or you ask them to show their mark sheet. And you compare, you know, what are the marks of surgeons and non-surgeons with regard to anatomy. That is another way. Of course, you know, I don't remember my anatomy marks. So a lot of them may forget, a lot of them may not actually have their mark sheets at present. So that's a problem. You know, people may not remember how much they secured in anatomy in first year, but that is another way. So the first way was that you go to first year MBBS students and you follow them up for 8, 10, 12 years to see who becomes surgeons, who don't become surgeons. And then the other way, the second way is that you go to surgeons, okay, and you ask them how much did you score in anatomy in first year. Those are two solutions. Any other solution? What is wrong? So anybody care to answer what is wrong with the first solution that I gave? So can I go to API conference and can I give out MCQ tests to all of the attendees? And can I just check if the surgeons are surgeons, if they are present, if they are securing better at anatomy in the MCQ test than non-surgeons? What is wrong with that? It's so easy. I can just do it at one go. Like I can just go to a conference. They're all sitting in the plenary session, all the attendees, and just give out an MCQ test. And what is the problem there? You can type in your answer, you can unmute, either way. Anybody care to answer what is the problem with that solution to this problem?
The person who are surgeons may be reading up anatomy books again and again, so they will definitely be more skilled.
Exactly, excellent. That's absolutely correct. So, of course, surgeons are going to score better, because in order to become a surgeon in their entire training, and once they do become surgeons to practice surgery, they have to know anatomy. So they have to study more and more anatomy. So it wouldn't be surprising if surgeons scored better than non-surgeons. But that doesn't tell us if good anatomy knowledge leads to them becoming surgeons. It may just be because they are surgeons is why they are good at anatomy, right? So that is the problem there. Right, so we have three solutions here already. We have the one where we went to MBBS students, we have the one where we went to surgeons, and we have the one where we went to API conference. Any other solution that you can think of? And let me give you a hint. So the first solution that you told me, where we went to MBBS students, first year MBBS students who had passed out, that is an excellent design because you're going actually from anatomy to their specialty. You're doing that follow-up. But the difficulty there is that you have to follow them up for so much time. Like you have to follow them up for 8, 10, 12 years. Now, that's a very difficult time, and people may go to the US, people may go to UK, you may not be able to find them, right? So is there any other way that I can go from anatomy knowledge to their specialty without that very long follow-up? So I still want to go from anatomy to surgery, but I don't want to do that such a long follow-up. Is there any way where I can avoid that long follow-up? I'll give you another hint. Is there any place in a medical college that has records of all batches that have previously passed out? Is there any place in a medical college that keeps records of all previous? Exactly, we can see any record. So where is that place in a medical college where you have the mark sheets of all previous batches? There's one place in the medical college. What is that place? Academic, exactly. So academic, it's the academic section or the dean's office, right? So MCQ, so record section, exactly. So dean office, exactly, correct. Excellent. So excellent interaction. I'm really thankful that you're interacting. So what I can do is that I can actually go to the dean office first, take out marks of a batch that passed out, maybe 8 years back. So right now it's 2020, so 2023, and I can take out the mark sheet of a batch that passed out in 2015, right? First year MBBS in 2015, or even further back, so maybe 2012 or 2002. I know any year they have all of the records that are there, and then I see at present are those people surgeons or not, right? So at present are they surgeons, right? So that is another fourth solution, right? So I didn't go to MBBS students who are presently in first year MBBS, but rather I went to the dean's office, okay? And still I did go from anatomy marks to surgeons, but I didn't have to do that, long follow-up of 8, 10 years. I still went from in the same direction, but I could do that based on records, right? Exactly. So those are 4 solutions. Any other solutions? Communicate with them about this. Exactly. So that is what. So I go to dean office and then I ask them over the telephone. What are you doing now? Are you a surgeon? What is your profession? Exactly. So that's the first solution. Any 5th solution you can think of? Any experiment you can think of to answer this question? You can unmute and answer. Any experiment? Okay, it doesn't, maybe it's not occurring to you, maybe you're thinking about it, but it's very awkward. But if one were to consider doing an experiment, what if it give extra training to half the batch of MBBS students, give extra, ensure that they are better at anatomy and ensure that they have better knowledge and then follow them up. So it's similar to the first study where we had that 8-10 year follow-up. So we went from first year MBBS to profession surgeons. But in this case, we are actually, administering the intervention. So we are the ones who are administering the intervention. That's the 5th design, right? So what you told me in this brief interaction are actually all of the study designs that are there in epidemiology. The first one that you told me, where you go to first year MBBS students and you see whether they become surgeons or not, that's a prospective cohort study. It's a prospective cohort study. You're going from exposure to outcome, right? The second thing that you told me, and then prospective cohort study, you can see is a very long follow-up. It's an excellent design, but very, very long follow-up, 8, 10, 12 years, sometimes even longer. The second solution that you told me was that you go to surgeons and non-surgeons. So you came to ILBS and you asked surgeons and non-surgeons about their first year MBBS marks. That is a case control study. So cases are those that have the outcome, controls are those that do not have the outcome. The outcome here is becoming a surgeon or not, right? So you went to surgeons, you went to non-surgeons, and you asked them what were your marks back then in first year MBBS. And you can see the problem there. I don't remember my first year MBBS marks. So recall is a problem with case control study, right? So that's a case control study. Even though somebody had mentioned retrospective cohort, but that's not a retrospective cohort, it's a case control. The third solution is a retrospective cohort study. So when you went to the dean's office, you didn't go to surgeons and non-surgeons, you went to the dean's office, you took out records of a batch that passed out 8 years back. So that is a retrospective cohort study. It is conceptually similar to going from first year MBBS to 8 years down the line when they become surgeons. Conceptually, you're going in the same direction. You're going from exposure to outcome. But the exposure and outcome have already occurred. So they've already occurred back in the past, right? So that's a retrospective cohort study. And when you went to API conference and you gave out MCQ tests to everybody, that's a cross-sectional study. So just giving out, it's a snapshot. So at one point, what is the situation at one point in time? And the fourth one where you did an experiment, that's a randomized. It could be non-randomized also, but typically the prototype of an experiment is a randomized control trial, where we were administering the intervention to half the population, right? So somebody has asked me, and thank you for that question. They said, what if we go to dean office and see marks of surgeon versus other branch? Will it be case control or retrospective cohort? So dean office, exactly. So if you go to a dean office, you will take out marks of MBBS batch that passed out previously, and then you will follow them up, in the sense conceptually follow them up. You will take out the mark sheet from the records and you will see who was good, who was not good at anatomy, and see at present whether they've become surgeons or not, right? That's a retrospective cohort study. So you're going from exposure to outcome, but the exposure and outcome have already occurred. That's a retrospective cohort study. Case control, if you want to decide whether a particular design is case control or retrospective cohort, you have to ask yourself one question only. And that is, the way that I am recruiting patients into my study, If it is dependent on whether they have the outcome or not, then it is a case control study. Cases are those with outcome, controls are those without the outcome. So if that is how you are recruiting patients, then what you're doing is a case control study. Okay. So that, I hope that clarifies your question, and please interrupt me again if you have further questions, right? So, right. So these are the main, let me start with the actual presentation now. The main study designs are basically, you have observational studies. So in observational studies, you have two main categories, cross-sectional studies and longitudinal studies. Cross-sectional are snapshot studies. So at one particular time, what is happening. Longitudinal, you have a particular directionality. So you're going either from exposure to outcome or from outcome to exposure. So there are two types here, case control and cohort. Okay, and we already spoke a little bit about it, but I'm going to tell you more in the further slides. And then the other main category is intervention or randomized control trials. Okay, and then you have something called meta-analysis, which we have half a dedicated session to. It is basically a study of studies. So when you want to combine the results of a number of studies together, statistically, it's a meta-analysis. And before that, there's entire due diligence, the part where you do the qualitative part, that is systematic. So that is basically a study of studies. So if we talk about classification of study design, if we say, what are the two main big categories, the big categories, you know, this and this? The two main big categories are experimental and observational, right? So experimental studies are, of course, you know, something exquisite. Randomized control trial is a prototype of an experimental study where we do randomization to create groups. And we will talk about what randomization is and all of these concepts related to RCT day after tomorrow. But it's an exquisite thing in the sense that it's a beautiful thing in RCT. In the eyes of an epidemiologist, it's almost a sacred thing because it has these wonderful mechanisms in place to ensure the validity of the findings. And randomization is a beautiful process which takes care of a lot of things that could possibly cause bias. So randomized control trial, you know, you can think about it like superior design. It's a very superior design. And it's something exquisite, it's beautiful in the sense that in order to prove a hypothesis, the kind of evidence that you get from RCT is unparalleled, right? So that's one big category. That's an experimental study where you can either have random allocation or not. So randomized control trial and non-randomized control trial. And RCT is amongst primary studies, the best kind of primary studies. This is the strongest evidence. The other big category is observational studies. And over here, you have two main categories. One is descriptive. So here you don't actually have a hypothesis in the sense you're not trying to compare anything. You're not trying to determine or find association. You're just trying to describe, you know, what is happening. You're trying to give a picture in the sense maybe you want to tell the prevalence of various risk factors, prevalence of the disease, just describe what is the current situation, proportion of different factors that you're measuring, this description. And then you have analytical. So in analytical, you have, again, two main categories, and that is cross-sectional and longitudinal. And then, so cross-sectional is like that API conference where we gave out MCQ tests to all of the attendees. That's a cross-sectional study. It's just at one point, what is the situation? There's no concept of directionality as such. And over here, two kinds of studies, cohort study and case control, where you have this directionality. So cohort study, you're going from exposure to outcome. So again, there are two types of cohort studies, retrospective and prospective. Prospective cohort study is what you had told me very beautifully, the solution to the problem where you had gone to first-year MBBS students and followed them up for 10 years to see whether they become surgeons. That's a prospective cohort study. And the second solution, the third, the other one that where we had gone to dean's office, right? And we had taken out records of a batch that passed out in 2015 to see whether at present they are surgeons or not. That is a retrospective cohort. So again, you're going from exposure to outcome, but the exposure and outcome have already occurred back in time, right? And then there's a combination of prospective and retrospective called ambispective, which I will talk about shortly, where you have that record-based exposure and then you further follow them up in time, right? So that's a cohort study. And always you start off with exposure in a cohort study, where you start off with, if you're studying smoking and lung cancer, you will start with smokers and non-smokers, right? The other longitudinal study is a case control study. So, right. So a case control study, again, you go from outcome to exposure. So the way that you recruit patients into your study depends on whether they have had the outcome or not. Okay, so that is a case control study. And then you ask them about their exposure history. So that's, I think that there's one question in the chat box, which I will just take up. All right, so differentiate between case control and retrospective cohort, right? So case control study, if you want to find out whether what you're doing is a case control study or not, then you just have to ask yourself one question. The way that you are enrolling patients into your study, does it depend on whether they have the outcome or not, right? So smoking and lung cancer, if what you are recruiting into your study are lung cancer patients and non-lung cancer people, okay? If what you're recruiting is this, and then you're asking them about their smoking history, then that is a case control study. So you're recruiting people with the outcome and recruiting people without the outcome. In a retrospective cohort study, you are not enrolling patients depending on whether they have the outcome or not. You are going to exposure only. So when you had gone to the dean's office, you had taken out mark sheets of a batch that is passed out 8 years back. So you're not going to surgeons and non-surgeons, you're going to exposure only, anatomy knowledge. But the exposure has occurred back in time, okay? So again, you're going from exposure to outcome, but the exposure has already occurred. That's a retrospective cohort study. Retrospective cohort studies are record-based. So the exposure history you have somewhere in record, and the exposure has occurred back in time, right? So if you want to understand this further, just remember the example where we had talked about anatomy knowledge and whether they become surgeons or not. If you go to surgeons and non-surgeons, ask them about their anatomy knowledge, that's a case control study. Okay, you're going to those with the outcome and those without the outcome. Retrospective cohort study, you're not going to those with outcome or not, but rather you're starting with exposure only. You're going to the dean's office, taking out mark sheets. Okay, so you're not going directly to surgeons and non-surgeons, you're going to the exposure. You're taking out mark sheets of a batch that passed out 8 years back, and then you're following them up. Conceptually, you're following them up, you're calling them up to ask, you know, what is your profession now? So you're going from exposure to outcome, but the exposure and outcome have already occurred back in time, okay? So it is basically the difference is, are you going from exposure to outcome or from outcome to exposure, okay? That's the basic difference. Okay. So moving ahead, if there are no further questions, can't seem to change my slide. Okay. So observational study, is your entry criteria of study subjects based on presence or absence of outcome? If your answer is yes, then what you're doing is a case control study, right? So again, smoking and lung cancer, if you go to lung cancer patients and non-lung cancer people and you compare their smoking history, okay, you're recruiting subjects on the basis of whether they have the outcome or not. So that's a case control study. If no, whether you plan to follow up the same subjects over a period of time to record events that have not yet occurred at the start of the study, that's a follow-up study or a cohort study, right? So what if what you're starting out with is exposure, then that is a cohort study. So this is the prototype cohort study design. So you start with risk factor, known as risk. So these are all synonymous terms, risk factor, exposure, predictor, you know, these are all used interchangeably. So you're starting out with risk factor or exposure, and you're seeing in due course who develops the disease, who does not develop the disease. That's a cohort study. So a cohort study has many advantages. It's a very good design because it establishes the sequence of events. It avoids bias in measuring predictors. So all of the advantages of cohort study become disadvantages in a case control study. So in a case control study, if you're asking people about their exposure, I told you I don't remember my anatomy marks, right? So you don't need to recall things you don't need to recall exposure history in a cohort study because you're starting out with those that have the exposure or not. So it avoids bias in measuring predictors, avoids survival bias. So what this means is that, if you're doing a case control study, then you can only recruit cases that have survived, right? So you can't take cases that were so severe that they died, because they will not be captured in your study. Whereas in a case control study, since you're following up patients over a period of time, you're starting with exposure and you're following them up to see who has the outcome or not, you will be able to capture those who had the outcome of mortality or not, right? So there's no survival bias here. It can study several outcomes at a time. So typically this is the case. If you've heard about a very famous prospective cohort study called Framingham study, Framingham is a county in the United States, near Boston. And it is the most famous cohort study because almost everything you know about coronary heart disease, if you know that cholesterol is a risk factor, then that is a result of the Framingham heart study. And so many other, major discoveries with regard to risk factors for coronary artery disease are a result of the Framingham study. It started in 1940s. So now the original cohort, their grandchildren are now being enrolled into the cohort, right? So 4th generation cohort. And typically, apart from even coronary artery disease, they study other things also, so all kinds of strokes and, other peripheral vascular diseases, other diseases also. So they actually following up a cohort over a period of time. And so you can actually study several outcomes. So for example, in AIMS, they were doing a cohort study that, studied both dementia and stroke, so who develops dementia, who develops stroke. So several outcomes can be studied together. And it is the only study where it yields true incidence. So incidence is number of new cases that develop over time. And a cohort study is the only one that yields this. And a true relative risk and excess risk. We'll talk about these terms when we talk about results of studies. Disadvantages, of course, it requires large sample sizes and it's not feasible for rare outcomes. Because since we are following up a population to see who has the outcome or not, for rare things like maybe cancers, it's not feasible because very few people will end up having the event after such a long follow-up. So the cohort studies are follow-up studies. And the entry criteria is not based on presence or absence of outcome. It is based on presence or absence of exposure. So exposure, predictor, risk factor, same thing. If you are doing the study before any outcome has occurred, then that's a prospective cohort study. And if you're doing it after the outcomes have occurred, then it's a retrospective cohort study. So in a retrospective cohort study, you're going from past to present. Prospective, you're going from present to future. Okay, and then it could be partly prospective, partly retrospective. This is an ambidextrous cohort study. So you start out as a retrospective cohort study. So record-based, you take out records of patients previously admitted. And then you do a little bit of follow-up in the future also. So that's an ambidextrous cohort study. So this is a prospective cohort study design. You're starting out with exposure, risk factor, and this is the present time. And then you're following them up to see who has the outcome or not. So that's the prospective cohort study design. In a retrospective, again, you are starting out with exposure. You're not starting out with outcome. Okay, you're starting with the exposure only, but the exposure has occurred in the past, right? So record based. So let's say there were patients, you take out records of patients admitted who had exposure to a certain drug. And you want to see whether at present they have some long-term side effects or not. Right? So that's sort of like going from the past to the present, right? So that's a retrospective cohort study. And then a combination of these two is an ambidextrous. So for the purpose of doing PG thesis, actually, the ambidextrous cohort study is becoming a very popular design because you are able to achieve theoretically a long follow-up because you have your patient records that you determine exposure from. And so a little bit of follow-up is retrospective. And then maybe for 4, 5, 6 months, you follow them up into the future also, right? So a little bit until you have your thesis data collection time, you can follow them up a little bit also. So that's an ambidextrous cohort study. And it's a very popular design for doing thesis because you're able to achieve that long follow-up of cohort study without actually having to follow them up into the future, right? So I'll stop for questions. If there are any questions, you can ask me right now. I can't see the chat box actually. Are there any questions, Dr. Preeti, in the chat box?
No, ma'am.
Okay, great. Thank you so much. So cohort study is a prospective cohort study where you're going from the present to the future.
Ma'am, there is one question right now.
Okay.
What is nested?
Yeah, I can see.
Yes, ma'am.
Right. Nested. So we have modifications of cohort study, which are nested case control and case cohort study. So I will talk about these in detail when I have a session on observational studies, right? So if to just briefly answer your question, a nested case control study is where you're doing a cohort, there's an ongoing cohort study. And then within that cohort, you have people who are developing the outcome. So you take them as cases. And then within the cohort, those who have not developed the outcome service control. And then you have a baseline exposure that you measured in the cohort. So baseline blood tests that you have frozen, or you have blood samples that are frozen, or you've measured some baseline characteristics, right? So cases develop, you take controls from the same cohort and you compare your exposure history. That's a nested case control study. I'll talk about it a little bit when I talk about observational studies in detail. But that's basically nested case control is where there's an ongoing cohort study and you do a case control study within that for those who develop a certain outcome. It could be an outcome that's different from what the cohort is studying, okay? So the advantages of a prospective cohort study is that you have more control over selection of subjects, of course, because at present, you are the one who is recruiting the subjects into the study, and you have them before you, and you have more control over measurement. So as opposed to retrospective cohort study where you're relying on record-based data, where you're relying on your everything, exposure is depending on how well the records were made, how maintained. Now there you don't have control over selection of subjects or control over measurement, but in a prospective cohort study, you're the one doing everything, so you can do it. And the disadvantage is, of course, very long follow-up and very, very expensive, right? For obvious reasons. Retrospective, so the disadvantages for advantages is they're less expensive and shorter duration, and the disadvantage is, of course, less control over selection of subjects and less control over measurement. Then you have your cross-sectional study, right? So cross-sectional study is just a snapshot. So just imagine there's a tree trunk, and you just cut it in the middle. So there's a cross section. You see what at one point, one slice in time. What is the situation. And so this is, remember, we gave out NQ tests in API conference to see whether surgeons score better than non-surgeons. And so we don't know. Maybe surgeons are better because at anatomy because they had to study anatomy during their surgery training. So that directionality, in technical parlance in epidemiology, is called temporality, right? So we don't know whether the cause precedes the effect, whether the cause comes before the effect. That time relationship we cannot establish in a cross-sectional study because it's not a longitudinal study. It's just a snapshot study at one point what is happening. But nonetheless, we can establish some associations So that's an analytical cross-sectional study, or it could be just purely descriptive, right? So if you're just giving proportions of certain factors, proportion of diseases, just describing generally what is the situation, that is a descriptive cross-sectional study. But if you are finding associations, you're determining the association, establishing a relationship between two factors, that's an analytical cross-sectional study, right? So again, if I find what is the association between anatomy marks and surgery profession, that's an analytical cross-sectional study. Okay? So at one point, how many people have the risk factor, how many people don't, how many have the disease, how many don't. Advantages, of course, you can study the several outcomes and you have control over selection of subjects, control over measurements. So say I want to know what is the prevalence of hypertension in a certain area, maybe South Delhi. Then I have control over measurements, selection of subjects, and maybe I can also study along with that the prevalence of diabetes by doing blood tests, right? So several outcomes can be studied together. Short duration, of course, because it's just a snapshot, it's slice in time. And actually, the first step of a cohort study is a cross-sectional study. So the baseline that we take in any cohort, that is actually a cross-sectional study, and all big cohorts actually publish their baseline data. That's basically you start out with a cross-sectional study, and then you follow them up. And this is a study that yields prevalence. So prevalence is overall how many people have the disease. Incidence is number of new cases, and prevalence is new plus old, so all cases. And so this cross-sectional study, we don't know new cases, we don't know because we're not following up, right? So we can't determine incidence in a cross-sectional study. We can never determine incidence. We can only know prevalence, right? And then relative prevalence, which is comparison. Disadvantages does not establish sequence of events. So as I have said, temporality. This is for temporality. We don't know whether the cause comes before the effect or the effect comes before the cause. We don't know because there's no follow-up. Also, there's potential bias in measuring predictors. Yes. And there's potential survivor bias because, again, what you are capturing from your sample are those that have survived. So those are the only people who can participate in your cross-sectional study, and those that were so severe that they died, they cannot be captured. They're not feasible for rare outcomes, and it does not yield incidence or true relativism. Right? So I told you incidence is number of new cases, and since there's no follow-up, we don't know how many new cases arose. And then true relative risk, again, I will tell you when I talk about results of studies. Incidence in exposed upon incidence and non-exposed is the relative risk, right? So that is again something that is yielded from a cohort study. Now, case control study. So case control study, we start out with those that have the outcome and those that do not have the outcome. Though in this context, cases refer to patients who have the outcome, right? So again, smoking and lung cancer, my cases are those with lung cancer, controls are those without lung cancer, right? So cases in control. I start out here, I start with those that have the outcome or not. And then I ask them about their exposure history. So I ask lung cancer patients, how much did you smoke? I ask non-lung cancer patients, non-lung cancer controls, how much did you smoke, right? And then I compare. So this is a case control study. And then you can see very clearly, the stark difference from a cohort study where we are going from exposure to outcome. Here we're going from outcome to exposure, okay? And hopefully that further clarifies the difference between retrospective cohort and case control. So case control advantages, it's useful for studying rare outcomes. Why? Because we are actually going out there and we're recruiting diseased people, right? So for rare things like cancer, rare things like congenital diseases, things that don't happen very often, we do a case control study to find associations with risk factors because, we have to actually go out and recruit those cases to become our cases in our case control studies. It's short duration because, there's no follow-up. We're just asking them about their history. and exposure. Relatively inexpensive, yes, because there's no long-term follow-up, and relatively small, so that's also why it's inexpensive. And it is one design which yields a measure of association called odds ratio, right? So there are two main relative measures of association. One is odds ratio and the other is relative risk. And again, these are two things that I will talk about in the next session when I talk about results of studies. But they basically tell you what is the strength of association between two factors. So say exposure and outcome, smoking and lung cancer. How strong is the association? And the more that this number is more than 1, so 1.5, 1.2, 2, 3, these are all positive associations. So 1 means there's no association, and anything more than 1 so is a positive association. And odds ratio is difficult to interpret. They are interpretational challenges, but usually if the outcome happens rarely, so if it's less than 10% of the time, then odds ratio and relative risk approximate each other. Disadvantages is that potential bias from sampling two populations. Very difficult to do a good case control study. Why? Because recruiting appropriate controls is one of the biggest challenges in epidemiology. Why? So, for example, if we are studying is diabetes a risk factor for coronary artery disease? This is our question, and I want to do a case control study. So this is my question: is diabetes a risk factor for coronary artery disease? So can anybody answer how will I do a case control study? Who will be my cases in this case control study? Diabetes and coronary artery disease. Who are my cases? You can just type it into the chat box, or you can unmute and answer. Cases will be those with coronary artery disease. Well, not diabetes, just coronary artery disease. So again, case control study, you're recruiting people depending on whether they have the outcome or not, right? So exactly, cases are coronary artery disease. Very good. So those that have the outcome, those that do not have the outcome, right? Are controls. So cases are those with coronary artery disease, and people who do not have coronary artery disease are controls. And my exposure is diabetes, right? Now, what if I told you that I take as my control population stroke patients? So my cases are coronary artery disease patients, and my controls are stroke patients. Okay, and the exposure of interest is diabetes. Would that be correct? And why would it not be correct? No, it's not correct. Exactly. Correct. But why not? Right. So basically, diabetes is also associated with stroke, right? So you correctly mentioned. So, that association will be nullified. On the other hand, say I take a very healthy population, I take athletes, so very, very healthy population, then that could actually cause a spurious association, because they have a lower than expected prevalence of diabetes. If I take stroke patients, they have a higher than expected proportion of diabetes. So, this is why case control studies are the most difficult studies to carry out correctly, because it's very difficult to recruit appropriate controls. And for that reason, case control studies are in epidemiology, we say it's the weakest design. It's very difficult to do a good case control study, because we never know, we never know if the control population is going to have a higher or lower than expected prevalence of the risk factor, right? So we don't know. So that's why this potential bias from sampling two populations, it does not establish sequence of events. It does not, well, this is controversial, but it does not, because what you're doing here, although it's a longitudinal study, but we're not doing a proper follow-up, right? So we're just asking them about their history. And to some extent, it may establish a little bit of temporality, but certainly not as good as a cohort study. There's potential bias from measuring predictors, yes. So again, remember, I don't remember my NACI marks. Similarly, people may not remember their exposure history correctly, right? And typically, those that have the outcome, those that are diseased, they tend to remember their exposure history better. So, for example, if I am talking about, mothers who have congenitally deformed babies, then they are more likely to keep thinking about their exposure rather than those with healthy babies, right? So they will remember even small things like dental x-rays, etc. Whereas those that have normal babies, they may forget about a small dental x-ray, etc. Right? So that's why recall bias, that's called recall bias, is always a concern with case control studies. Again, potential survivor bias, because what we can recruit into our study are only those that have survived, right? So we're taking out cases and controls based on outcome, but those cases that were so severe that they died, we cannot recruit them, right? So that's survival bias. Limited to one outcome variable. So in a case control study, you can actually only study one disease at a time, one outcome at a time. Of course, one may argue that you can take disease controls as, but then there's another methodological issue with that. So typically one outcome at a time. And it does not yield prevalence, incidence, or excess risk, but rather we're stuck with a measure of association called odds ratio, which I will talk about later. But even case control studies indirectly are able to calculate risk indirectly, but not true relative risk. So when we talk about observational studies, the strengths are pretty clear by now. The interventions when it's not feasible or ethical. So for example, if I tell you I want to study what is the effect of mobile phone radiation on brain cancer, developing brain tumor, I can't ask people to talk on the phone more. I can't do that. What I can actually do is only an observational study. Similarly, if there's something harmful like smoking and lung cancer, I can't ask people to smoke, right? So potentially harmful. So very often interventional studies are not possible, and in that case, we have to rely on observational studies. But they have advantages of being rapid and efficient. We can rely on existing data. They take less time, expenses are lower, and of course, for rare outcomes, as I had explained earlier, case control studies are appropriate because we're going out and recruiting those cases. Limitations, as I have said, in terms of validity of findings, the findings from a randomized control trial are unparalleled. You can't match that with an observational study if the RCT is feasible. And that's why observational studies are subject to a number of biases and a number of confounding factors. As we have seen with that case control study, I told you briefly, I'll talk more about it later, but I told you briefly that there are major issues methodologically with recruitment of cases and controls. So it's subject to bias and confounding, and there's limited power to study rare exposure or rare outcomes in the case of cross-sectional and cohort studies. Right? Now, one thing that is very often published during the course of MD are case reports and case series. So I'll just briefly mention this, that a case report is a detailed report of a single patient, and a case series is basically characteristics of a number of patients with a given disease. So a number of rare disease patients are coming to your ward, and you think, this is worth writing up. Then of course, you can do a case series. Or if there is a particular very special presentation or a very rare disease or very rare presentation, then one can publish a case report. Advantages is, of course, studying in science, creating case definitions, useful for education. We talk about natural history, and for things like side effects of drugs, case series, case reports are very worthy because something rare, happens. If it's a rare, adverse event, etc. Case series and case reports are very useful for generating hypotheses. Right, so if there's something happening rarely, something peculiar, so that can actually help you. It aids in developing hypotheses. Right, so there, it's actually a very good design where you want to generate hypotheses. Disadvantages, of course, there's little sample and absence of comparison group. So, again, a lot of alternative explanations cannot be ruled out. This is a distinct design. There's a distinct design called ecological studies, where the unit that we are studying is not an individual, but rather it is a group of individuals. So what I have depicted here is a graph. On the x-axis, you have per capita daily meat consumption. So what is the per capita daily meat consumption in these countries? And here on the y-axis, you have colon cancer incidence, right? So you have meat consumption here, colon cancer incidence here, and we have plotted here the average for the entire country. So every dot here represents a country. And so here we're not talking about individuals, we're talking about groups of people. So in this case, is the population in the entire country. And so you can see here that as per capita meat consumption goes up, the risk of colon cancer goes up, right? This is an ecological study where we're just correlating. We're correlating two factors for a group of people. And, it has major limitations because we don't know if what is true for the population is true for the individual. So, for example, we don't know whether those that are getting colon cancer in these populations, if they are the ones who are actually consuming more meat or not. We don't know. It may be that those that are getting colon cancer are the ones that are very less meat consumption. It's just that the correlation is positive for the group. So that is called ecological fallacy. So what is true for the population is not true for the individual. But just worth mentioning here, it's not really to be amenable to being done in a thesis, but just wanted to mention that there are correlational studies where our unit that we're studying are population. The advantages is that it is quick and expensive. We have the ability to study wide range of exposures and understand the ecological effects. And disadvantages, you cannot, it's not possible to link an exposure at the individual level. So again, as I have told you, we don't know whether those that were consuming more meat are actually the ones that develop colon cancer or not. We don't know that. For an individual level, we don't know. The population, we know that as more meat consumption is happening, more colon cancer is happening. That's ecological fallacy. But ecological studies mostly are again useful for generating hypotheses. You can't test the hypothesis, so you can't confirm that meat consumption leads to colon cancer, but you can generate a hypothesis. So you can actually generate a hypothesis that you can test in individuals, right? So that's where the value of ecological studies comes, generating hypotheses. And then finally, we have interventional study designs. And I told you, I'm going to talk about in great detail randomized control trials in the next session. And I advise you to stay tuned for that because we will be discussing methodological issues and reporting guidelines. But basically, what we're doing in interventional study design is that we are deliberately giving an intervention to a group of subjects in the study, right? So we are determining who gets the exposure, who does not get the exposure. And this allocation of intervention may be in a randomized fashion, that's an RCT, randomized control trial, or it may be non-random. So we don't do randomization, we just sort of administer the interventions according to convenience. That's obviously less robust, but there are non-randomized studies also. And then there are quasi-experimental studies, so before, after design, where there's no control. We compare pre and post-intervention, right? So I'll stop here, and what we have next is an interactive session. But before we do that, I'm going to ask you if you have any questions, and if you do, then let me please know by unmuting and asking your question, or by you can type in your question to the chat box. So whatever you find more convenient, and I'll give you just about 10-20 seconds to think if you have any questions. Otherwise, we'll go to the interactive session where we have an interactive poll. Right. So again, so I'll just recapitulate the interventional studies and experimental studies and observational studies. Okay, and experimental or interventional studies, we have RCTs and non-RCTs. And in observational, we have cross-sectional studies and longitudinal studies. Within longitudinal studies, we have case control and cohort studies. And within cohort studies, we have prospective and retrospective cohort. Right? So now, case control study is also classified as prospective, retrospective, but that is beyond scope of this session, right? So if there are no further questions, somebody said cross-sectional. Is there a question related to cross-sectional?
Ma'am, they are giving answer for the question that you have put on the slide.
Oh, okay. Well, you don't have to answer it right now because we have an interactive poll, right? So what I'm doing here is just flashing the question here, and there's going to be a poll that Mr. Ravi is going to flash on your screen, and you can access that poll from the poll tab in your Zoom. Okay. So this is the question. You are a newly appointed doctor in a hospital. During your clinical duties, you came across many patients with fatty liver disease, especially females. And you decided to explore this issue by conducting a study in villages in the field practice area. The objective of your study is to know what proportion of people have the disease among females in these villages. You also want to study various factors associated with fatty liver disease. You're interested in groups which have higher proportion of fatty liver. Which study design will you choose and why? And then you have your 4 options. And I'll give you about maybe 30 seconds to answer, and then we'll close the poll. Okay, I think we can close now. I think maybe 35. Have people answered?
10 have voted, I think.
Okay, so we can wait then. Oh, they say it says 11 out of 11 have answered. But why is it showing?
Total it is 34 participants, out of which 11 have voted.
I see.
Now 13.
I see. There are 14 people that answered.
Yes.
There are 18 people who have to yet answer. I think we'll close it in another 20 seconds. Okay. 20-30 seconds. Dr. Preeti, what do you think? Should we close?
Sorry, ma'am?
You let me know when you think we should close the poll, yeah?
I think now no more respondents, 18.
Okay.
So we can end the poll.
Okay, we can end the poll and present the results. So 15 out of 18, most of you, 83% of you that voted said cross-sectional, which is correct. So absolutely, the cross-sectional study is the correct option, because here we're talking about prevalence of fatty liver disease, right? So proportion is same as prevalence. Proportion, prevalence, same concept. And so to find out proportion of prevalence of people who have a certain disease or an outcome or a risk factor or whatever, in a certain given population, there we take a cross-sectional study typically. And then also you can along with that study various factors also associated, because I told you a cross-sectional study can be analytical cross-sectional also. So you can take prevalence of exposure, prevalence of outcome, and then we can actually study the association between exposure and outcome, right? This is, again, I told you, cross-sectional study is like taking a snapshot. It's a snapshot study, and it's basically telling you what is the situation at any given point in time, right? Oh, he presented all of the polls together, but we only had question 1. Okay, so I'll move to the next question. So I'm going to present the question, and then you can vote for poll 2. So this is the question. You have recently come across some mothers who have delivered babies with congenital malformation. On inquiring about any illness during pregnancy, when you have a history of an intake of over-the-counter domperidone for nausea and vomiting in first trimester. You are interested in knowing whether there is really an association between birth of congenitally malformed babies and intake of domperidone during pregnancy. Which study design will you choose? You can start voting now. You have to vote for question 2 now. If you scroll down on the poll tab, this is where you will find question 2. Okay, so should we stop? Okay, so these are the results. Okay, most of you said case control, so that's correct. Case control is correct. Why is it correct? Why not a cohort study? So how you do a case control study in this is that you will go to people who have the outcome and those that do not have the outcome. And so those mothers with congenitally malformed babies and those with normal babies. And then you will ask them about the history of domperidone intake, right? But why can't we do a cohort study here? Why can't we start out with those mothers that are taking domperidone and then following them up, and those that are not? Or we asking them, why can't we do a cohort study for this? What's the difficulty? No, but like outcome is occurred here, but maybe why can't I actually go to AMC clinic and I ask mothers about domperidone intake, whether they took it or not, and then I follow them up for till their delivery time and see how many had malformed babies. Why can't I do that? Okay, we'll give you more time to answer. We can do it, but what is the challenge there? What is the prevalence of congenital malformation? Very less, it's very rare, exactly. So the challenge there is that it is so rare that even if you follow up 100, 200, 1,000, 500, 1,500 mothers or pregnant women who become mothers, you will get very few cases of congenital malformation. Maybe you will get maybe just 1 or 2. Even if you're lucky, you might. By high probability, you won't get any. But maybe if you will get 1 or 2. So in that case, for rare things, that's why a cohort study is not appropriate. So for rare outcomes like congenital malformation, what you have to end up Sorry. What you have to end up doing is basically a case control study, right? But then again, the challenge with case control study, as I had said, was that those mothers with congenital malformed babies, they are more likely to remember their exposure. Why? Why are they more likely to remember their exposure? Those that have congenital malformed babies? Because they'll keep thinking about it, right? So they keep thinking, what did I do wrong? What happened that I had a congenital malformation in my baby? And so that's why those with outcomes in a case control study are definitely more likely to remember their exposure history than those that do not have the outcome. And this is called recall bias. So correctly, Dr. Siddharth has written in the chat box correctly, that's a recall bias. And this is what it is. It's recall bias because cases are more likely to remember their exposure history compared to control. But still appropriate design here is still case control, because we have something that's very rare, right? Obviously, we can't do an RCT here because we can't expose mothers to domperidone. When there's a question of possible congenital malformation, we can't do an RCT. And a cross-sectional study will not tell us anything about the directionality or the temporality or the association robustly enough to really test this hypothesis, right? So that's why cross-section study is inappropriate, right? So moving on to the third question, oral contraceptives have been incriminated as a cause of increased risk of hepatocellular carcinoma and gallstone disease in women. On the other hand, it has been reported that they help in reducing the risk of colorectal cancer. In order to explore this issue, you endeavor to establish the role of contraceptives as harmful and or protective agent. Which type of study design will you choose to establish the association between oral contraceptives and these diseases? So I'll ask Mr. Ravi to please start the poll for the third question. So you have to scroll down, right? You come down to question 3, and that is where you answer. People are still answering, so maybe we'll wait for 30-40 more seconds. Okay, so Dr. Preeti, do you think we should stop the poll?
Yes, ma'am. I think no more respondents.
Okay, great. Right, so majority of you again got it right. Majority of you said cohort study, which is correct. It is the most appropriate design here. Why? Because what we are studying here is multiple outcomes, right? So we want to know, is it protective in terms of some cancers? Is it harmful in terms of others? And so our exposure is one thing, oral contraceptives, but our outcomes are multiple. So colorectal cancer, maybe other types of cancers also. And so you can actually follow up a population and see what is the effect on multiple outcomes, right? So, cohort study is correct. Case control, we can't do here because there are multiple outcomes that we're interested in. Case control study is most appropriate when there's a single outcome that we're studying, because we are recruiting cases in control depending on whether they have the outcome or not, right? So that is why case control study, single outcome. And cross-sectional study will not establish the association between exposure to oral contraceptives and cancer. And RCD we cannot do because we can't subject women to oral contraceptives. We can't randomize them to get oral contraceptives. So again, correct. The correct study design is a cohort study. And so the way we will do this is that we will go to women who have exposure to oral contraceptives and those that do not take oral contraceptives, and then follow them up. So we follow them up many years. There's a latency period which is very long for cancers and gallstone disease. So long follow-up, and then we see how many of them develop the outcome. This is multiple types of outcomes that we're interested in: endometrial cancer, colorectal cancer, right? Okay. And then finally, we have our last question here. And the question is, during your posting as a PhD, in the PhD as an intern, you had come across many cases of hepatitis B. You were always fascinated by various vaccines that are being used and further developed. Now, as a researcher working in the same disease, you have read about a new vaccine which claims to have better protection rates than the existing one. You want to conduct a study to find out which vaccine gives better outcomes. Which study design will you choose? So I'll ask Mr. Ravi, please present the poll. So again, you have to scroll down to question 4, and you can vote. Right. So I think we have most of the answers in now. And again, also, most of you have answered correctly, and that is a randomized controlled trial. So when we're talking about efficacy of an intervention, right? So be it any intervention, a vaccine or a drug or a device or any health education intervention or anything that you want to see the effectiveness or the efficacy of, there we have to do a trial. So you want to know whether a drug works or not, whether a vaccine works or not. All of them must have to be subjected to a randomized controlled trial before they can really come out. So every drug that you have out there has to be subjected to multiple series of different types of randomized controlled trials. All the COVID vaccines have to be subjected to a trial, right? So all interventions that have to be rolled out to study whether they work or not. So efficacy, that's called. That is always yielded from a randomized controlled trial, right? So when you talk about whether the intervention works, none of these study designs, so sectional, cohort, case control, will adequately address that question. The only one that adequately addresses efficacy of an intervention is a randomized control trial. And that is why an RCT is the correct answer here. And certainly, when you talk about new vaccines, etc., all of them have to be subjected to a randomized control trial before they can come out. Okay. So, any questions that have to be addressed? Any questions? You can just type them into the chat box. And thank you so much for participation for the interactive session. Very encouraging, and I was very happy to see a positive response, and most of you got it correct. Now, the last section, we were going to talk about formulation of hypotheses, but I've already finished my 50-minute time slot for the lecture. So maybe I'll just quickly go through the slides on formulation of objectives in view of the time. So when we talk about study protocols, we have spoken about study design so far, but what precedes it, what comes before it, is actually formulation of research questions and formulation of hypotheses. And even before that, you have your introduction or background or significance. So, after that, everything else comes, right? So, research question, all studies should start with some sort of an uncertainty, right? This is something that we don't know. So all studies should start with a research question that addresses what the investigator would like to know. And the goal is to find an important research question that can be developed into a feasible and valid study plan. And in fact, there's something called the research cycle. So you start with that uncertainty, right? That uncertainty, the lacunae in knowledge. And because to address that lacunae and that uncertainty, we develop a research question. And then we design a study. We implement the study, analyze the results, infer conclusions from this study. And these conclusions further again lead to some uncertainty, right? So again, that leads to development of the research question. So this is how the research cycle works, and this is how, we go about designing studies for research. And the format for the research question could be either in a descriptive format or in an analytical format. For descriptive, we say in a population of whatever the study population is, what is the prevalence of the outcome? So in a population of females in South Delhi, what is the prevalence of hypertension? Or in females of a given community health center population, what is the prevalence of fatty liver disease, right? So this is the descriptive research question, and most studies will have more than one research question, and this research protocol flows from the research question. But when we talk about analytical studies, so when we talk about analytical studies, what we're talking about is things like to determine an association, or to determine some factor as a cause, or to find the association, or to find some sort of you're studying about hypotheses, that this is associated with this, or to determine something as a cause of this. That's analytical studies. And in this, you have a different usual format is in a population of whatever is some factor associated with another factor. So in a population of elderly, is diabetes associated with chronic kidney disease, right? So associations are always analytical, and this can be in a cross-sectional form or in a longitudinal form, that doesn't matter, but in the study design. But this is how the usual format for the research question is the analytical study. And there are components to research question in the form of PICO, patient intervention, comparison, and outcome. And this PICO comes at a lot of places. So in the series of lectures that we're going to go through, you will see PICO a lot, because PICO, PICO, patient or population also this refers to. Intervention, typically, I is typically intervention, but could be independent variable, input variable, index test for diagnostic studies. Comparator is what C refers to usually, but also control and comparison is used interchangeably with this. an OS outcome. Usually it should be a patient-oriented outcome like mortality or cardiovascular disease, etc., or any patient-important outcome, health outcome. And so this PICO, you will encounter a lot of presentations in the future also, because this is the basic structure of the research question. And there are many variations of PICO. So sometimes we don't have an intervention, we only have exposure, right? So say you're finding the association between fatty liver disease and cardiovascular disease. So where the patients of fatty liver disease go on to have cardiovascular disease later on in life. There's no intervention, but there's exposure, right? So there it becomes PECO. So there's a variation of PICO. Similarly, sometimes in a research question, the study design matters a lot. So there it becomes PCODES, right? Study design is also there. So, there are different variations. Sometimes there's only P and O, only population and outcome. So, for example, in a cross-sectional study, we don't have intervention, we don't have comparator, only patient and outcome. So it's just PO. There's a lot of different variations. But remember this, patient, intervention, comparator, outcome, PICO, the components of research question. Example, in a population of injection drug users with HIV infection, is heart use associated with fewer opportunistic infections? So here population is injection drug users, intervention is heart, outcome is fewer opportunistic. And basically the comparator here is implicit. It is no heart use, right? So this is the PICO that we have for this research question. In the population of pregnant females with epilepsy, is treatment with sodium valproate associated with higher risk of neural tube defect? So here we don't have an intervention in the sense that in intervention that is being treated as an exposure, right? So sodium valproate is exposure, pregnant women with epilepsy is population, and comparator is no sodium valproate, and the outcome is higher risk of neural tube defect. So quickly telling you the characteristics of objectives. Go back. When we talk about objective or research question, a research question is in the form of a question, right? So does addition of dexamethasone to standard antibiotic therapy in adult patients with community-acquired bacterial meningitis decrease the risk of mortality and severe deafness compared to standard antibiotic therapy alone? So this is again, the PICO format is here. You can see that the PICO is here, but it's in the form of a question. On the other hand, objective is not in the form of a question. It goes like the primary objective of the study is to determine. So you will have verbs like to determine, to ascertain, to determine, ascertain, to find, so things like that you want to do. You want to do something. That is how objectives are formulated. So everything else is the same. But then over here in the objective, you also are a little more specific. So you mentioned the dose of dexamethasone. You mentioned the time at outcome that you're interested in, measured at 3 months, So some other things are further delineated when we formulate objectives from our research question, right? So this is in the form of a question. This is the matching objective. Now, when we talk about formulation of objectives, there are some characteristics that we must consider. The objective of the study must be feasible, interesting, novel, ethical, relevant, and scientifically sound. That's the Finer's criteria. So the Finer's criteria. What is meant by feasible, of course, is that you should have enough resources, enough money, enough expertise to be able to carry out the study. Interesting, so it should enthuse the investigator, enthuse who is reading, enough to generate some sort of an interest. Novel means that it should either confirm or refute or extend previous findings. Ethical, of course, so it has to be ethical, self-explanatory. You can't do an unethical study. So, as I had told you earlier, whether talking on the phone leads to brain tumor is very interesting. It's novel. But you can't subject people to extras on the cell phone. It's not ethical. You can't do it. Relevant, of course, and scientifically sound. So, Finer for feasibility. Feasibility refers to whether you're going to be able to do it or not in terms of resources and cost and time, etc. So adequate number of subjects, adequate technical expertise, affordable in time and money, and manageable in scope. Right? So this is the criteria for feasibility. For novelty, it should confirm, refute, extend previous findings. So confirm, refute, extend, and maybe it could provide new findings. Right? So anything that meets these criteria is novel. Relevant, of course, to scientific knowledge, to clinical, public health or health policy, or to future research direction. So relevance in terms of making a contribution to any of these areas. And we already spoke about this. So let me just quickly go through, So how to state the objectives? So as I have said, we have to use action verbs to determine, to compare, to verify, to describe, to establish. So these are the typical ones that we use to formulate objectives. And to study is not a good verb to use in objective. To study is not good. To appreciate, to understand, these should be avoided. So typically you would want to use these ones to determine, to compare, to verify, to describe, to establish, especially, of course, for analytical studies. And then there is something called hypothesis, which is a statement that describes the expected outcome of the research or study. Now, for purely descriptive studies, you remember we spoke about descriptive and analytical studies. Purely descriptive studies are those that just tell you what is the situation, so what is the prevalence of hypertension, what is the general opinion on a certain, I don't know, maybe politician or whatever, just describing general opinion or prevalence or general situation scenario out there. Those are descriptive studies where we don't have hypotheses. So we don't have hypothesis-based research. So for example, if you're just describing the proportion of different bacteria that have been cultured in hospital specimens, that's just descriptive studies. There's no hypothesis. Whereas hypothesis-based research are those that, again, you're finding an association, you are determining something as a cause. Although cause in epidemiology is the most evasive thing to establish, but still you're attempting to study something as a cause. You are finding an association, determining something, all those are hypothesis-based research. So writing the hypothesis is not in the form of a question. It is a declarative, right? And it identifies those components of the research question. It identifies the relationship between the two variables that you're hypothesizing have a relationship. It should be testable, operational, and states the expected outcome. So back when we had talked about our research question objectives, example for that, corresponding to that is, in adults with acute bacterial meningitis, dexamethasone added to standard therapy decreases the risk of mortality and severe deafness compared to antibiotic therapy alone, right? So the research question is in the form of a question. The objective where we specify more and we put it in terms of what we're trying to determine the association between this. And then in the hypothesis formulation, it becomes a declarative statement. So we're not asking, we're declaring that this happens. This is our hypothesis. And then we do our study and we either refute the hypothesis or we confirm it, right? So we either refute it or we do not refute it, either way, So that is what we do after our study is done. So to summarize, let me, I think I missed my summary slide. There are various types of research design. And broadly, if you talk about the two main designs, they are experimental and observational. Within observational, you have longitudinal and cross-sectional studies. And within longitudinal, you have case control and cohort studies. And within cohort studies, you have retrospective and prospective cohort studies. RCTs are a form of experimental studies that have randomized allocation of exposure. We will talk about it in detail in the next session. There are various advantages and disadvantages of various study designs. RCTs are superior in terms of establishing causation. It is a more valid result. but they're not always feasible. You can't always administer an intervention, particularly when there's something that may cause harm. So if you're determining an exposure that could possibly lead to an outcome that's harmful, then you can't do an RCT. And that's why we have to rely on observational studies very often. However, to study the efficacy of an intervention, so in that example, the vaccine or any drug or any device or any other intervention, health intervention, population level intervention, they should be subjected to a randomized controlled trial in order to determine efficacy robustly. And within observational studies, there are various types of, various advantages of each, and appropriate scenarios of doing each, and those examples that we had in the interactive poll demonstrated that. And finally, for formulation of objectives, there are different criteria called the Finos criteria. And the same research question can be formulated in the form of a hypothesis or in the form of an objective. Hypotheses are declarative statements, and objectives are, of course, what you're attempting to do, so to determine the association, etc. And objectives must meet those Finos criteria in order to be well formulated. So with that, we come to the conclusion of the first session in this series, and I encourage you to ask any questions if you have any. If you want to unmute and ask, you can ask. Other than that, I encourage you to stay tuned for the next few sessions. We will be talking about randomized controlled trials in the next session, and subsequently to that, results of RCTs and observations. So over to you, Dr. Preeti.
Thank you very much, ma'am. It had been a very interactive session. I believe that all the PG students who have joined would have got a very good knowledge about the basic research methodology. Now I'd like to invite Professor Ajay Sood sir to give the vote of thanks.
It is indeed my great pleasure to thank Dr. Manya Prasad for making this difficult session so simple for the student. These series of lectures are basically meant for our junior resident, first, second, and third year. And based on the feedback which we had received from the experience from January to March, many of the students had mentioned that the session should be made more interactive. So I really congratulate Dr. Manya for making this session very, very interactive, where I think most of the participants were able to interact with the speaker. So thank you so much. And secondly, this is a difficult area. Research and epidemiology, mathematics is usually difficult for our medical faculty, fraternity. But Dr. Manya Prasad has made it very simple with the examples. And I am really very grateful to her for kindly agreeing to take this series. As far as the students are concerned, we are grateful to you for enrolling for this series. And again, I will request all the students who are present in this particular session to encourage your fellow student to join this. This program is for you. And if you join in large number, send us your questions, send us your queries, send us what topic you want us to cover in the future series of lectures. If you have gone through the e-brochure, which we have circulated to you, on the last part of the e-brochure, we have the links. So if one of the link will help us to get feedback from you, you can always click on that and send us your feedback about this particular session. Then you can also send us question for the future session, because we have circulated you the program schedule for the entire week. So whatever your question, whatever your queries for the next session, kindly communicate to us on that particular link. We will communicate to Dr. Manya, and she will try to cover those questions specifically in the next session. Then another link we have made where you can have access to the previous lecture series and section which we had from January to March. So please go to that also, and maybe it may be useful for you. So once again, I thank you all who have been able to attend this particular session. Our great thanks to all of you. And once again, thanks to the speaker for this day for making this session so much interactive. And I would also like to place on record the contribution made by the moderators, Dr. Preeti. Thank you very much, and see you next time. Thank you.
Thank you so much, sir. Thank you, Dr. Preeti, and thank you to all the participants. Hope to see you next time. And please circulate the link amongst your colleagues as well. Thank you, everybody. Bye-bye.
Thank you so much, ma'am. So I declare the today's academic session closed. Thank you.